We're going to go over chapters 1 through 4 for a health assessment. And normally I would do this sooner, but we got a little bit behind here. So this is a quick review just based off of the information that she had given us to study. So it's just key factors here, things that we need to look at. Okay, starting off with chapter 1. Chapter 1 is your introduction to assessment. All right, so it's going to go over, you can't see that. There we go. Chapter 1 is going to go over your introduction to assessment. So, boy, you stuck. Let's try black. It's horrible. Okay, so it's going to go through your intro. Let's define the state of health first. So the state of health, essentially, and of course you can remember the quote if you want to, but essentially based off of the World Health Organization, it is the complete physical, mental, and social well-being of well-being, and not just the absence of disease. So not just the absence of disease. And remember, it is holistic. So physical, mental, and social well-being. All right, Healthy People 2020. Healthy People 2020. We talk about this all the time. It is a framework. Basically, what it does is it identifies diseases of concern, risk factors, ways to improve health, and it's based off the 10 years. So it's 10 years, every 10 years. It also has education and focuses on the decrease in disparities. As far as nursing goes, the assessment is used to identify areas that a patient has where they might fall into risk. So when you go to do your assessment, you're assessing your patient's risk for having one of the things that relate to Healthy People 2020. All right. It's based on Healthy People 2020 is based on your past evidence, your current emerging issues, current diseases, so past information, current information, diseases of concern, and problems that are coming up. All right, so that's Healthy People 2020. All right, the next thing that we need to be looking at is prevention. With prevention falls under your first, second, and third. The way to remember this is that the first is pretty much safety and health, well-being. So health, well-being, and safety is your primary ones. It also talks about the provisions of housing, which is the services of the house that you live in. All right. 2 is early treatment and detection of minor diseases to prevent further complications. And 3 is the third prevention is basically we're going to try and prevent loss and disability from issues that we already have. So basically we are trying to make sure that it doesn't get any worse. So that is your first, second, and third preventions. As far as you're looking at your patient, part of the RN's job is to determine what prevention that she can use or he can use to, so let's say the patient has a risk of falls, maybe we can use the first prevention. All right, well, now they already fell, it's minor, now we're going to go into maybe a walker from Walmart, or screening for loss of consciousness, things like that. So that's first, second, third. The role of the nurse as far as assessment goes. All right, that's the other thing we had here. Role of the nurse as far as assessment goes. Assessment is the foundation of nursing. We already talked about that. All right. So assessment. The role of the nurse is initially to gather data on the patient. Other things that they're going to do is make sure that they provide or look at the patient holistically. So anytime you're doing assessment, you're looking at the 6 facets. I will go into that in a second. Make judgment on patient safety. And figure out which prevention, the first, second, or third that you can use there. IG daily needs. So what's the need ID daily needs. What's the needs of the patient on a daily basis? What are they looking for, or what are they needing help with on a daily basis? Whether that be a sickness, ADL, and it's important during the assessment process that we watch for changes in our patient. Right, that's one of the nurse's roles as well. Okay, so we're watching for subtle changes. And we are always going to be reassessing. Let's referring back to my notes. All right, we're always going to be reassessing. Now, 6 facets. That's the other area we need to focus on. Before I said spec DC, I'm going to show you a couple of different ways. All right, P, M, S, D. All right, so you have P, M, S. All right, and then your other word right here. All right. And you can just sound that out all the way through. So the 6 facets of health. Before I had said emotional, but you also see mental come up. So P is going to be physical. M is your mental, but it also is referred to as your emotional in some areas of the text. All right. S can be either spiritual or social. D is for development. C is for culture, and S is, in that case, is going to be for social. Now, as you look at these, you're going to need to be able to define each one. Obviously, we know what physical is. Their physical disabilities, limitations, things that and maybe it's good stuff too. Mentally, how are they holding up mentally or emotionally? Are they upset? Is there some reason to suspect abuse or financial strain, or some other factor there that's affecting their health? Spirituality, let the patient guide this. Don't try and guide this for the patient. You are trying to help the patient. So if they want to see a chaplain or a priest or a Buddhist monk, all right, you're facilitating that, but let the patient guide that. Developmental, like I said before, it's not just education, but it can be problem solving or complex problems that they need help with. It can also be a value-based issue. So maybe it comes down to do not resuscitate type issues. Cultural, find cultural information or support for them. And social, they might be closed off, so be prepared to have that social groups or things that they can reach out to find a way to be social. Right? So those are the 6 factors, and you use the 6 factors during the assessment process. You use the 6 factors when you assess your patients to find a holistic approach to your patient. So 6 facets. And again, make sure you are able to detect changes in your patient so that you can provide the best care. Always reassessing. Alright, so that's the 6 facets. That's going to end you on chapter 1. Now we're headed into chapter 2. Alright, and again, we are just hitting the major key points needed for the test. Alright, chapter 2 is critical thinking. There's a lot in this, but again, I'm only hitting the areas that we need to focus on. Alright, subjective. Alright, subjective is coming from the patient or the family. It's the way they experience sickness, and again, you experience sickness, it's called illness. Disease is what's actually happening, and illness is how it affects the patient. Alright, so this is coming from how the patient tells you, or how the family tells you, the patient's history, medical history, chief complaint, why are they there, and if they don't have, it might just be that they need an annual assessment, and they're using it as a preventative maintenance, health maintenance. Excuse me, I have allergies. Alright, and the review of systems. Alright, so if I ask you, how's your skin? That's a review of the integumentary system, and it's subjective because it's coming from you. Of course, objective, on the other hand, is going to be might be labs, physical exam, and a review of the system from your healthcare team or the nurse, depending on who's doing that. But remember, healthcare team is a body of people, multidisciplined, PT, respirators, whatever, CNA. So subjective, objective. Old cart. Alright, as you go through this objective information, your patient's going to tell you, my right shoulder hurts, and then of course they're going to want to know more information, and they generally won't provide that, but a way to guide their old cart, a way to guide them to get a better understanding of the symptoms is, so onset, when did it happen, location, specifically, duration, how long has it been around for, alright, and then we have, let me start back here, treatments that the patient has tried. No, associated manifestations, things that allow for relief, and you want to know what treatments they used before, because otherwise, one, you could be trying something ineffective, or two, they could have taken something or done something that was going to cause additional issues, depending on what it is. And C, and all of a sudden I just went blank. C is your condition. So old cart, again, you're using that to specify, and I just want to double check this real quick, because Lord knows we don't want to get it wrong. Alright. Oh, yeah. Characterization. This one's hard. So this is your symptoms. What's it feel like? What's it act like? And a lot of times you're going to need to use therapeutic communication to kind of give different answers. It's sharp. It's dull. I can never answer this question when somebody asks me that. Alright, so onset, location, duration, how long has it gone on for, characteristic symptoms, as far as your pain goes, associated manifestation, when I have a headache, I can't see any longer, or vice versa, and then R is your leaving, so it relieves to walk around or close my eyes or whatever the case may be, and then treatments are what they have tried for it, and again, that's important because one, it could interact with something. You could have medication interactions, or two, you might be trying something effective. Okay, so that's old cart, ADPI. Of course, we all know ADPI, and this is throughout your text, but as it relates to critical thinking and assessment, there's a couple things we want to hit on. So you first are going to assess, and this is where you're going to come up with your problem list. Your problem list is another area that we need to hit on. Heck, we'll just expand it now. Alright, so use a list of all your issues. You should have active and inactive issues, and it should be listed in severity. Okay, so it says severity from top to bottom. Also, you want to make sure you give it a number for medical records. And I actually didn't remember that until I read the text over again. But a number. So 1, you have you can't breathe. Alright. 2, you have acne. Okay, something of that nature. So that's your problem list. And it lists everything out, active, inactive, from most severe to least severe. Okay, that is part of your assessment. And again, when you're assessing people, you're using that 6 facets to make sure that you get the holistic view of the patient. Alright. So development. You're assessing, developing. Now that so your diagnosis, your nursing diagnosis, that it should relate to your problem list, obviously. Remember that your nursing diagnosis is not a medical diagnosis. It's a diagnosis of the way that people experience disease, which is again called illness. So it's the human reaction. All right. So we're going to assess, we're going to diagnose, we're going to plan. All right. In your planning, you should make sure that you incorporate the patient, because the patient is very important to your overall. The patient needs to be incorporated in all of your planning, because if it doesn't work for the patient, it's not going to work for the nurse. Alright, so it should also have long and short-term goals. Intervention. Intervention can be done not only by the nurse, but also by the patient, or by the family, or the healthcare team. It should always be individual. Obviously, this is not a cookie cutter thing, so it's individual to that patient, and it needs to be modified as changes occur, so that we can make sure that we are making the best treatment for the patient. And then, of course, evaluation, and this is a continuous thing. It's a continuous thing, and it confirms the nurse's role, and by evaluating, we can prove that our treatment worked, and that's how we are giving the nurse's role validity. All right, so that is ADPI. Okay, the other problem, we already went over problems list. Let's make sure we hit everything on that. Nursing diagnosis. The problem list, again, it should, from here, from my problem list, I can get the nursing diagnosis. Health maintenance, that's another thing to hit on. Health maintenance is frequently listed now in your problem list, so don't forget about that. There's no specific order of how to take this down, but we do want to list it like I had already stated. And make sure that it's individual to the patient, obviously. Okay. Alright, so that's your problem list. Moving on, chapter 3. Alright, chapter 3 has to do with the interview and communication. Okay, so chapter 3. First of all, we have the phases, and this wasn't really in there to cover, but I'm going to cover it anyways. You have the pre-interview where you're getting all the information that you need. You're going over whatever records you have in the interview. You're making sure that everything is comfortable. And you're doing self-reflection. So that's pre-interview. You're preparing for the actual interview. Then we have the intro. The intro basically establishes rapport with the patient. Make sure that you greet the patient and anybody in the room. Make sure that you provide confidentiality. So if you are about to do a physical exam or go through information, make sure that the person in the room, that it's alright with the patient for them to be there. So that's your intro. Then you have your working. Of course, during your working interview, you're going to get subjective information from the patient. Now, it kind of blends into other areas as well, but for the most part, as long as it's coming from the patient or the patient's family, it's subjective. So, and then of course you have your termination. During your termination, you're summarizing everything that you went over, making sure you didn't miss anything, setting up additional appointments, and a way forward, really. It's a way forward. Alright, so that's your termination. And you shouldn't just walk out of the room. Okay, so during your working part of your interview, in the event that your patient gets upset, you need to immediately identify that, and we do that. We react to emotional patients by using NURES. We're naming, understanding, and we're respecting. Okay, so naming is so you feel stressed, or you're feeling a lot of stress over this. Understanding is I can understand how you would be upset over this, and respecting is many people don't deal with it as well as you do. So you're naming, understanding, and respecting, and that's how you react to an emotional patient, or when you pick up emotional cues. Alright. Also, during the working process, you're going to go through questioning, and that relates to therapeutic communication, but let's just focus on the question part right now. So the question part, one, we use old cart for symptoms. So old cart is one tool. Alright, also you want to use guided questioning, and this might involve a graded response. You ask one question at a time. I'll just write one at a time. You might give multiple, and this is what doctors always have to do with me when they say, what type of pain is it, and I can never describe it. You have to give multiple answers to it. Alright, so is it this, is it this, is it this, kind of helps. And then of course, continuers. So continuers is, yes, I understand, or nodding your head, or giving those nonverbal communications, saying, yes, I'm listening and I understand what you're saying. Alright, so now that is questioning. And like I said, questioning falls under therapeutic communication. So let's cover the rest of therapeutic communication. Alright, therapeutic communication involves active listening. So that means that I'm attentive, I'm obviously engaged in the conversation, I'm not just typing in the computer. Also has to do with nonverbal, so that means make yourself at eye level of the patient. Make sure that you're not just looking around the room or acting bored. Remember, you deal with emotional patients using that NURSE acronym. You provide validation to your patient. Right? Doesn't necessarily mean you agree, but you respect what they're saying. You provide reassurance. Again, don't provide false reassurance. Oh, you're going to be okay. You know, stage 1 billion cancer, you'll be fine. So make sure it's realistic. All right, summarize. Always summarize the communication. The reason why we do that is to make sure we didn't miss anything and to let the patient know that we were listening, and that falls under therapeutic communication. Transition. So if you're going from one topic to another, tell them that you're transitioning. Otherwise, they're going to continue on with another conversation. Empowering the patient. That's important. Empower patient, and you do that through education, teaching. All right, education and teaching is the primary ones there, but all right, the other thing about therapeutic communication, you might need to use it with an angry patient. That was another thing that we're supposed to hit on. Angry patient. So let's say the patient is agitated, not throwing the sharps container at you, but just agitated. Make sure that you listen. All right, stay calm. Accept patient's feelings. It doesn't mean you have to agree with them, but you can accept their feelings. Don't gang up on somebody. So if they say, Dr. So-and-so is horrible, just say, I can understand how it can be frustrating, but don't say, yes, he is horrible. What else? Once they've calmed down, then you want to find steps to make sure that it doesn't happen in the future. Because if they're angry once, they'll probably be angry in the future. And also assess yourself, did I do something wrong that made this patient angry? Alright, let's say they are very agitated and they're throwing stuff at you. First of all, call security. Alright, don't try and calm them down initially. Just listen to what they're saying and see if you can't pick up on what the major problem is. Once they've calmed down a little bit, or you have a better understanding of what they're upset about, then you want to try and get them into a room or someplace secure, so that way that you can talk to the patient and help them calm down. But again, you want to listen. Oh, also act non-threatening. So, if the patient's throwing stuff at you, don't try and fight them. Don't try and defend. Well, not necessarily defend, but don't try and wrestle them to the ground. Try and sit there and listen. So non-threatening, okay? A relaxed state the entire time. That's how you deal with an angry patient. And that was alright. FIFE is another tool that we have. So FIFE is used to understand how the patient experiences the disease, which again I said was illness. Alright, so we want to understand the patient's fear. It's not right patient, let's write fear. Fear or concern. Okay, we need to understand the ideas about nature of this illness, about nature of illness or possible cause. We need to understand loss of function or loss of ADLs. and the expectations of the disease or possibly the hospital or the nurse. All right, so fear or concern, ideas about how the illness came about or what caused the illness. F is for function, loss of function specifically, and E is expectation. So how one person feels about, um, again, going back to the being sterile thing, not having children, how one person feels is not going to be how other people feel. So this person might fear that they have lost worth. They might not ever get married. They might believe that they are sterile because one time they took a drug when they were 12. Functions of ADL, for some people this might not be significant. For other people, maybe they no longer go outside. So now they're shut in. No social interaction. And the expectations is either the disease or the nurse or the hospital. In this case, maybe they expect to die alone. Alright, so we need to understand this, and having this tool allows us to understand how a patient experiences the illness, and we should have the same understanding as the patient as far as the illness goes. So that way we can identify what's really working at hand. Alright, so that is going to be chapter 3. Chapter 4 is our last one for this video. Chapter 4 is going to be health history. Alright, so types, and this was confusing to me, but types of health history. Alright, so types of health history, under types of health history, you have the different assessments. Alright, so assessments. So you have a comprehensive one, which again is in a non-emergency situation. It's usually on admission, and you are going to get all types of information. You want to get past medical. Alright, so that means allergies, that means surgeries, illnesses, childhood illnesses. You also want to get family history. So get the genealogy, family history, history of heart disease, stroke, cancer. You want to get identifying information, that's name, date, birth, social, figure out what the chief complaint is, and again, it might just be that they want an annual assessment. Family history, we talked about that. Review of systems. Alright, and that's from the patient's perspective, so it's going to be subjective. And history of present illness. So if they do have a chief complaint, the history of that present illness. Is it acute? Has it been a chronic issue? What type of treatment have they done in the past? Health maintenance. The good, the bad, and the ugly. So the health maintenance. When you talk about health maintenance, think of the first, second, and third preventions, and then also incorporate the bad. I smoke, I drink, I drive without my seatbelt, whatever the case may be. So that is your health maintenance. If you're going through this assessment, let's just say you're doing a complete assessment, or a comprehensive assessment, and you find out that the patient has been drinking a lot, you can use Alright. You can use the cage method, and I guess if you get arrested, you will be sitting in a cage. But so have they ever felt the need to cut down? Have they ever been annoyed by somebody trying to tell them to stop? Have they ever felt guilty about drinking that much? And have they ever opened, well, this is eye open, but open their eyes in the morning and decide that, well, it's 5 o'clock somewhere, but really it's 5 a.m. and they're drinking already. So that's your acronym: CAGE, cut down, being annoyed by people telling them to stop, guilty about their drinking habits, or they wake up in the AM and they are drinking. Okay, so back to the types of health history. So all of those things can be present in your comprehensive assessment, which again is a type of health history. But let's say we already have the comprehensive assessment, then it might be a focused, and this is a returning patient, patient that the nurse already knows, and they have a symptom that needs to be focused on. And you can use that old card there, of course. Also apply the 6 facets. Excuse me. Alright, the other was the follow-up history. So follow-up history. So in the follow-up history, we've already identified an illness, and let's say we gave them an antibiotic, and we had that follow-up to make sure that 1, they're compliant, 2, they're getting results, 3, it's it's not spread or gotten worse. Okay, so that's your follow-up. Of course, you're going to evaluate there, and then you have your emergency. Your emergency is somebody's gone into the ER because they cannot breathe. So your emergency situation is going to be your life-saving measures. Is a systematic approach, systematic treatment of needs based on your ABCs. All right, so it's very systematic. Can you breathe? Such an airway. Excuse me. So that's your emergency. And then later on, of course, we'll go back to your comprehensive in an emergency situation. Alright, and that is chapter 4. Alright, I will go through 5 through 8 on another one.